Thank you, Dr. Tariq, for this invitation, and I'm really pleased to be speaking to you today. I fully agree with my previous speakers. Looking after children with neurodisability needs to be an MDT care approach. I'm very pleased to be part of the MDT team that works along Dr. Tariq and other members of our team. And I support the nutritional and gastrointestinal support for the children with neurodisability. We all need to work together to improve these children's lives and outcomes. So today I will be talking to you about the nutritional and feeding issues that we see in children with neurodisability. I have no affiliations or conflict of interest to declare. And really, this is no secret. Children with neurodisability have gastrointestinal problems, and this can be up to 90% of cases. They also have feeding problems, and this can happen in up to 50% of children. And this can affect the nutritional state of these patients. A study performed in Belgium demonstrated that up to 50% of the children with cerebral palsy had a form of malnutrition, and this applies to other children with neurodisability. And so, if a child has poor nutrition, we know that he will have impairment or problems with their cerebral function. There will be immune function problems. There will be a disturbance in their quality of life. And this will make them need more medical care and medical services. And so it is an important part of assessing these children is to ensure that we manage their gastrointestinal symptoms and nutritional states. And today I will be talking about that, and I'll be touching base on some of the common gastrointestinal problems and how we can manage and tackle these problems. So your initial assessment is when a child comes to you through the door or through the clinic door, and you're thinking, this child looks like he has mild disability or more severe disability, or sometimes they come through and you're not sure how severe is their disability, and you form an initial impression. And then you go ahead and start taking your history and physical examination. And part of my history needs to involve feeding history and GI symptoms. When I perform my physical examination, I need to assess the nutritional state of the patients. I look for red flag signs, and I try to establish what part of the gastrointestinal system is involved. Key questions that you need to know when you take a feeding history that raise red flag signs include, how long does the child take to complete a meal? And if it's more than 30 minutes, then you need to think maybe you need a more supportive way to support this child's feeding. How stressful is the feeding for the child and the family? And you need to check if the child's choking or having recurrent respiratory symptoms, because this is a major concern for these patients. And then you complete your history and you start with your physical examination and you try to assess the nutritional state of this child. The first thing you do is look at their growth charts. And we have to be aware that some children have their own growth charts, children with cerebral palsy, children with Down syndrome, and there are other growth charts for other disorders. Try to plot them on the correct growth charts. However, our children, when we try to assess their growth, it is quite difficult. Some children have scoliosis, they have fractures, they have contractures, they're not very cooperative, moving them is very difficult. And the height and weight measurements can be quite difficult. So scientists and physicians try to find ways where we can assess their nutritional state, their height, in different ways that can make it easier for the children. One of the ways is measuring the segmental length. So for example, measuring the tibia. There are special charts that can tell you how, and calculations to tell you the estimated height or length of the child. We also try to look at the trend of their growth, try to look at their weight for height, try to see their BMI. Other ways to assess the nutritional state is the mid-arm assessment circumference. It's a very easy way to assess. There are clear charts and growth charts to assess the mid-arm and see if they are nutritionally in a difficult situation. Another way is to measure the fat fold, and there are again charts and tables to let us know what's the nutritional state of the child. Then, after history and physical examination, you try to formulate an assessment, whether the problem is an intake problem or there's another problem going on. And like any other child, these children can have other diseases. So we need to really do a complete assessment for them. We need to look for secondary problems. We do blood tests, we do stool tests, and we also do bloods for a nutritional assessment, iron, vitamin levels. Sometimes we need imaging and more specialized investigations such as endoscopy and pH impedance studies. And by the end, you try to decide whether the child has a swallowing disorder, is gastroesophageal reflux, gastric emptying disorder, small bowel disease, colonic problems and constipation. Is the child failing to thrive? And a really key thing to make sure that we don't miss is recurrent respiratory infections and aspiration pneumonias. And this comes to my next topic, which is the swallowing disorders. So these children who have recurrent respiratory deterioration, one of the problems could be that they are aspirating. And if they are aspirating and we're allowing this to continue to happen, then their respiratory condition will deteriorate, and respiratory problems have been one of the leading causes of premature death in these children. So assessing the swallow is something very important that I need to make sure when a child comes to me that he's swallowing appropriately. And some of these children just have incoordination in their swallow. But as you can see from the figure here, the photo here, when the child swallows, one of the most important mechanisms that happens is that the airway is closed by the epiglottis, and the airway is protected, and the food bolus goes into the esophagus. With these children, this mechanism can be impaired and they can be chronically aspirating into their airways and their lungs. And this can be assessed with a video fluoroscopy. So this is a dynamic study where we ask the child to swallow, and images are taken as the child is swallowing, and then we can detect whether there is the radio opaque material is going into the airway or just goes down in the right place. And we assess if the child's swallowing is normal for liquids and for nectar consistency materials. Because some children are not safe with liquids, but they're absolutely fine with thickened food. And all we need to do is just give them thick food and allow them to have, and if they need to drink water or milk, we thicken their liquids. However, if I get a child who has aspiration, this makes my job even more difficult, because I need to know if the child is just aspirating when they're eating, or are they also refluxing and aspirating? And this is quite difficult to establish clinically. And when I'm really concerned and I'm worried that is the child refluxing and aspirating, then I need to go to the next step, which is performing a pH impedance study. This is a study where we insert a very small catheter into the esophagus. The catheter has multiple sensors along it, and these sensors will detect whether the child is refluxing, how many times the child is refluxing, and whether the reflux is going all the way up to the esophagus. the upper esophagus. This child is having the study. It's a 24-hour study. We insert the catheter for 24 hours. We get the readings, and it gives us an idea whether the reflux, how high is the reflux and how frequently it is. So as you can see, the catheter is barely seen. It's very small. It is not a very complex procedure. And when the child is actually aspirating, but not refluxing, it's very easy. We decide if he's safe to have thick food, and then we allow him thick food. If he cannot have thick food or liquids, then unfortunately the child cannot have, we have to protect the airway, so the child cannot feed orally. However, if the child is aspirating and also refluxing, with reflux going high into the upper esophagus, then this child is at risk of reflux and aspiration. And these patients will either require fundoplication, and with a gastrostomy, or these children will require jejunal feeding, so a gastrostomy with an extension and feeding them past the stomach, because we have to protect their airways. However, some children just have gastroesophageal reflux. They're swallowing fine, but they reflux, they cough, they vomit. These patients can be managed either with lifestyle modifications, sitting the child up, putting the bed up. We adjust the feeding regimen by giving them thickened milk, or by weaning them early if they are babies and have a safe swallow. We can give them small, frequent meals, or we can give them, if they have a gastrostomy, a continuous feed. So small volumes in the stomach will allow them to reflux less frequently. Most of the children who are refluxing are on medications, and sometimes we have to do more invasive procedures if we cannot control the reflux with medications and lifestyle changes and feeding changes. The second problem that we can see in children with small intestinal disorders is motility problems. We get children who come to the clinic with abdominal distension. When we do an X-ray, the X-ray is full of gas, and this is mainly related to the abnormal motility of the small intestine. We can give simipicone if the problem is a bit of gasiness and there's not much symptoms. Sometimes we give probiotics, and that can help these patients. Sometimes they get small bowel overgrowth because the bowel is not moving, so we give them antibiotics and we cycle the antibiotics. And some children, despite all these measures, they do not get better and they have a very difficult life, and we end up putting them on a gastrostomy with multiple aspirations and drainage, and at the extreme end, some of these patients get ileostomies. Constipation, I'm sure you see many children with constipation, with neurodisability and cerebral palsy. It's very common. This is related to their abnormal motility. We give them we make sure they're well hydrated, they're getting adequate fluids. We add sometimes fibers to their milk. We can give them stool softeners, and the stool softeners are generally in the form of Movicol. We can give stimulants, and in the extreme cases, again, sometimes we get these children to have regular rectal enemas. I would not recommend the phosphate regular enemas. These children need to be on saline enemas. Phosphate enemas does have, on a prolonged use, does have complications and is not recommended. Again, we assess failure to thrive. Failure to thrive most of the time is an intake problem. We try to, but if there's any GI reflux, we control it with medication and optimizing their medications. We optimize the calories. We ensure they have adequate vitamins and there's no vitamin deficiencies. We treat other problems like reflux, and some of these children will require gastrostomy or NG tube feeding. We can insert gastrostomies in these children. And many of these patients need tube feeding. There are many devices that can be used, but the gastrostomy button is the most commonly used. I'm sure you've seen many patients with this type of device, which is the black one on the top. So in summary, gastrointestinal problems and malnutrition are very common in children with neurodisability. Recurrent chest infection is a red flag sign. We need to make sure that our children are not aspirating. And I need to highlight some of these children who are aspirating have no symptoms whatsoever because they don't have good receptors to induce a gag reflex. So they may be aspirating and not choking on the food. And we can, as a team, gastroenterologists, neurologists, and all the members that help these patients improve the outcome of these patients. And thank you very much.